I'll be talking about CF-related diabetes and what causes it and why it matters to people with CF. And really, I'll be focusing on these topics. There's a lot more to CFRD than what I'll be covering today and can cover in the time allotted. But hopefully I'll be able to address this really important question. All right, so first off, why does it matter if people with CF have diabetes? The burden of care from other medical treatments of CF is already really complex. At the onset and diagnosis of diabetes, arguably many people may not feel symptoms of diabetes. And interestingly, historically, the argument existed that people with CF might not live long enough to develop what we classically think of as complications related to high blood sugars, such as eye disease and kidney disease. But really, a lot of research has emerged over the last couple decades, really highlighting the importance of CF-related diabetes for CF health, and that's what I'll be covering today. So CF-related diabetes is associated with increased morbidity and mortality. As of the latest data, CF diabetes is associated with, and this has been shown in a number of studies, a 3 to 4-fold greater risk of death compared to CF patients who have CF and don't have diabetes. And the CFRD is the result of insulin deficiency, which leads to weight loss and elevated blood sugars. And these high blood sugars can increase infection, inflammation, and affect lung function. And over the course of this talk, I'm going to go into these two components in more detail. But first off, some data regarding mortality outcomes in people with diabetes and without diabetes. Now, this figure is a key figure with data generated from the University of Minnesota. And this, the CF Center at the University of Minnesota has led the CFRD research has really been led by Dr. Antoinette Moran, and they have been one of the centers with the most rigorous screening for CF-related diabetes over the last 3 decades. And they have just done a really good job of screening all their patients with CF for CF-related diabetes. And in the 90s, when they first published some of these data, what you can see here in the solid lines are data from females and males who have diabetes compared to patients without diabetes. And what you're seeing here is a more than 10-fold increased risk of mortality in patients who have diabetes compared to those who don't. Now, over the years, with improved treatment, more aggressive treatment of CF-related diabetes with insulin, you can see that this mortality gap has decreased. So that as of the latest data in the 2000s and early 2010s, this mortality gap has increased significantly. However, in patients with diabetes compared to those without, there still is a more than 3-fold greater risk of death in patients who have diabetes. Now, this has been shown in registry data as well, and there have been some really nice data from the UK registry that have shown a 4-fold risk of death from diabetes compared to patients without. This shows data by age, comparing patients without diabetes in the white bars, and patients with diabetes in the black bars. And what we can see here is that across the lifespan, diabetes is associated with an increased risk of mortality. These are data looking at hyperglycemia, so high blood sugars, and the association between blood sugar and risk of death. And these are looking at, again, UK registry data, where over 500 individuals with CF were followed for 2 years. And at baseline, what they did was they looked at patients with diabetes who had A1Cs above 6.5% versus below 6.5%. And at baseline, they were similar in age, sex, BMI, and pulmonary function, as well as use of steroids. After 2 years, 36 individuals died. And when they compared A1C in those who died compared to those who didn't, A1C rates were higher. And they concluded that this A1C over 6.5%, they looked at this, was associated, again, with an increased risk of death, a triple that diabetes tripled your risk of death, as demonstrated by the hazard ratio here. Other data looking at medical interventions, and these are data from the US patient registry, have shown that diabetes is associated with an increased need for medical interventions. So these are data comparing over 1,000 patients with diabetes compared to patients without diabetes. And what we can see here are that patients with diabetes have an increased need for therapies. So pulmozyme, airway clearance, bronchodilators, NSAIDs, not NSAIDs, but oral supplements, enteral supplementation, steroids, oxygen, and diuretic need. So how prevalent is CF diabetes? In the US, there are over 31,000 individuals with cystic fibrosis. And again, these are data from the University of Minnesota, which has done just a really nice job of screening patients with for CF diabetes. And what their data show are that in adults over the age of 18, 30 to 50%, up to 50% of the population will develop CF-related diabetes. Up to 20% of young adults and adolescents develop CF-related diabetes. And it can even be seen in kids under the age of 10 years. And reports have suggested as high as 2% or more. Although typically patients under 10 aren't often being screened routinely at most centers, but they may be picked up for other reasons due to increased exacerbations and potentially glucose is detected during admissions. All right, so what causes CF diabetes? CF-related diabetes is primarily a disease of insulin deficiency. In other words, the pancreas does not make enough insulin. And we'll talk about that a little bit more in the next few slides. Insulin resistance is also an important thing to understand. And what this is it's a state where the body may make insulin and may make a lot of insulin, but the tissues in the body don't respond to the insulin that's being produced. And this is an image illustrating globally what this process looks like. A very simplified version of this. So after eating a meal, eating carbohydrates are broken down, and the glucose or sugars are absorbed into the bloodstream. Okay, the pancreas then has an important role of making insulin, in addition to other functions, but the pancreas has the important role of releasing insulin, this hormone, into the bloodstream, which acts as a key. I like to think of it as a key or a bridge to allow the sugars in the bloodstream to get taken up by the cells in the body and used as fuel. Glucose is a really important source of fuel to help muscle do its work. And it's also taken up by the liver as a source of storage fuel and to be used for later. And in states where the pancreas isn't producing enough insulin, there's insulin insufficiency or insulin deficiency, glucose can't be taken up by the cells, and glucose levels in the blood start to rise. In this figure, this goes into more detail, illustrating really the many contributors to the development of diabetes in people with cystic fibrosis. So the mutations in the CFTR gene result in a defective CFTR protein, and CFTR, as we know, is present throughout the body, but specifically in the pancreas. Many folks are familiar with the exocrine impairments of cystic fibrosis, and this leads to thick secretions that obstruct the pancreatic duct, and over time lead to scarring of the pancreas, fat infiltration into the pancreas, and beta cells, which are the cells that produce insulin, are scattered throughout the pancreas. And the scarring and inflammation of the pancreas leads to, over time, problems with release of insulin, delays and decreases in insulin secretion, which contribute to CF-related diabetes. Now, we know that CF is also associated with infection, chronic infection, inflammation, This, over time, leads to insulin resistance. And there's also really emerging data that inflammation directly contributes to beta cell dysfunction. So impairments in how those beta cells work and lead to decreased insulin secretion. And these factors can lead to, so this inflammation, recurrent exacerbations, infection, lead to this insulin resistance that we were talking about. That can be periodic. Many patients prior to development of CFRD may not have obvious insulin resistance, but certainly during periods of stress, of illness, with need for steroids, so prednisone bursts, these are things that can all contribute to insulin resistance. Insulin resistance at the level of the liver leads to increased blood sugars, and all these factors contribute to development of CF-related diabetes. I wanted to point out this decreased muscle mass component here, particularly for this audience. Muscle, as noted earlier, skeletal muscle is really important for uptake of glucose, and decreased muscle mass can also contribute to decreased uptake of glucose and contribute to the development of CF-related diabetes. It's important to understand that CF-related diabetes is different from type 1 or type 2 diabetes. And I always like to take some time to review this, because many folks, when they first hear about CF diabetes, have heard about or know somebody with type 1 or type 2 diabetes. And in fact, most of the literature that you may come across online about diabetes pertains to type 2, but may not be specific, and usually isn't specific to CF. And it's important to understand some of these differences. So type 1 diabetes is actually the most common type of diabetes we see in pediatrics, endocrinologists see in pediatrics. And it's autoimmune in nature. And what that means is the immune system, which normally helps us fight off infection, it actually targets those insulin-producing cells in the pancreas, those beta cells, and it wipes them out. So that by the time someone presents with symptoms of type 1 diabetes, insulin secretion is almost nearly wiped out. And when the body is unable to make insulin and does not have any insulin around, it actually can be really dangerous and put people at risk for something called diabetic ketoacidosis, where protein and fat start to break down, and it can develop something called ketone bodies and can make people really, really sick. When there is insulin around, ketoacidosis is unusual. I won't say it never happens, but it's pretty rare in other forms of other forms of diabetes. It's certainly not seen to the frequency that is seen in people with type 1 diabetes. In type 2 diabetes, this is really worldwide the most common type of diabetes that exists, and most of the literature out there pertaining to diabetes that you may come across online pertains to type 2. In type 2, early on, it's primarily a disease of, we were talking about this insulin resistance. It's a disease of insulin resistance early on. The body may make huge amounts of insulin. The pancreas may make huge amounts of insulin, but the tissues in the body don't respond to that insulin that's being made. And over time, those insulin-making cells can burn out, and there's a relative insulin deficiency. So there's not enough insulin around for the body's needs. And to address it, we can encourage people to lose weight, try diet and exercise to try to increase that insulin sensitivity in the tissues. This doesn't apply to CF. So CF diabetes, it does have components, as mentioned before, of insulin deficiency and insulin resistance, but it's different. And you may some folks may have heard the term type 3C diabetes, and that's another term for CF-related diabetes, or diabetes that's related to problems with the pancreas directly, inflammation of the pancreas, that are not type 1 or type 2. So it's a different entity. And in thinking about why we treat CF-related diabetes and the importance of it, it's really important to think about CF diabetes in the context of CF. At onset, CF diabetes may actually seem milder than type 1 because that degree of insulin deficiency isn't as profound as type 1 diabetes, but that insulin deficiency still has really important implications for someone living with CF. So microvascular complications, just thinking about long-term, they can be seen in all forms of diabetes, and it's related to high blood sugar. So what are these microvascular complications? So it's damage to the eyes, to the kidneys, to the nerves related to chronic high blood sugars and impairment in blood flow to target tissues. And we see this in type 1 and type 2 diabetes, and it can also be seen in patients with CF-related diabetes. Just briefly, macrovascular complications, those are complications such as heart disease, strokes. Those are some of the top morbidities related to type 1 and type 2 diabetes that we target with treatment. We do not see this yet with CF-related diabetes, at least thus far. This hasn't been described, although I have heard of potentially some case reports. But in the literature, macrovascular complications haven't yet been described in CF-related diabetes. But as people are living healthier and longer lives, I think this is something that is important to pay attention to. And it's important to note that the #1 cause of death in patients with type 1 and type 2 diabetes is cardiovascular disease. In CF diabetes, it's lung disease. And so we really need to think about treatment in the context of CF. And the recommended treatment for CF-related diabetes for that insulin deficiency is insulin replacement. Just to highlight some additional factors that are unique to CF, undernutrition is often a huge concern. Patients with CF have increased energy expenditure. Their caloric needs are higher, and they're often on high calorie, 3,000, 4,000 calorie a day diets. There's inflammation with illness that can lead, and oftentimes, particularly in patients that are undernourished, there can be chronic inflammation, and on top of that, infections can lead to intermittent inflammation, steroid bursts, which can be good for calming lung inflammation, can lead to high blood sugars. There's altered gut nutrient absorption and transit time, and CF liver disease is also known to be a risk factor for CF-related diabetes. All right, so how do we diagnose CF diabetes? And I'm not going to go into a whole lot of detail about this, but these are the diagnostic criteria listed here. And of these, the most common diagnostic tool is the oral glucose tolerance test. And this is something that many of you are probably well familiar with. And with people who don't yet have diabetes are expected to undergo annually and this oral glucose tolerance test. And during the oral glucose tolerance test, a 2-hour glucose or blood sugar is measured. And when that blood sugar is over 200, that is consistent with CF-related diabetes. Now, typically in the absence of symptoms, we recommend a confirmatory test, but we could also make a diagnosis of diabetes based on elevations in glucose with classic symptoms of diabetes, or if elevations in glucose are noted with 2 feedings, or even during exacerbations if you're sick. We've often recommended that when patients are admitted into the hospital for exacerbations, that their glucoses be monitored. And if we're detecting hyperglycemia, that can also make a diagnosis of CF-related diabetes. And really, this isn't something that develops overnight, right? It develops after years of progressive gradual decline in insulin secretion. And what we know now really is that the majority of individuals have some degree of insulin deficiency. And this progresses over time as the pancreas, as the beta cells in the pancreas are affected and insulin secretion decreases. What these figures show are changes in glucose during the oral glucose tolerance test, comparing people who don't have CF to individuals with CF. And what we can see here in the dark circles are the changes in glucose in over 3 hours in response to the oral glucose tolerance test. In individuals that are pancreatic sufficient, you can still see alterations in glucose in response to the OGTT with higher glucoses here. Although by 2 hours and on further on, oftentimes glucose levels come down, concentrations come down. And then individuals who don't yet have diabetes, you can see here that even despite prior to a diagnosis of diabetes, you can see here that the glucose levels start to rise. They can be elevated at the 2-hour mark. Typically in individuals without diabetes, that 2-hour glucose is below 140. They can be elevated at the 2-hour mark or even earlier. And then when diabetes is present, glucose levels are significantly higher. C-peptide is a hormone that often in research is used as a surrogate for insulin and insulin secretion. So this is another way to look at insulin secretion over the course of this oral glucose tolerance test. And you can see here, again, in these dark circles, that in individuals without CF, there's a rapid rise in insulin production within the first 30 minutes immediately after drinking that glucose. However, in individuals with CF, and again, these are pancreatic sufficient individuals here in the open circles, there's a delay in that insulin release, so that peak insulin, it takes longer to get there compared to somebody without CF. And in individuals who are pancreatic insufficient, we can see even greater delays in insulin release and decreases overall in insulin secretion by the time frank CFRD occurs. So how does CFRD cause clinical decline? So insulin deficiency. Insulin is a really potent anabolic hormone. It promotes conservation of body protein, fat, and carbohydrate stores. And malnutrition and protein metabolism, a breakdown of protein, are associated with a worse pulmonary function and increased risk of death. What are some of the metabolic consequences of this insulin deficiency in people with CF? So individuals who are malnourished or really sick are severely protein catabolic. You're breaking down protein. Interestingly, even healthy, nourished CF patients can have subtle defects related to this insulin deficiency that can affect protein and fat breakdown and may compromise nutrition. And there's a thinking that this protein and fat breakdown can be prevented if we can restore that insulin insufficiency and replace insulin. Okay. What about high blood sugar? What are the consequences of hyperglycemia? Hyperglycemia impairs how the immune system functions. It affects how those white cells fight off infection. It can lead to dehydration. It can lead to increased viscosity of mucus secretions. Again, it leads to protein breakdown, fatigue, and we know that bacteria like glucose. It's a source of fuel for them too. So there have been studies associating hyperglycemia with a higher prevalence of Pseudomonas, Staph, B. sebaceae, Aspergillus. So bringing down those high glucoses is really important. I think this is a really nice study. And the figure I'm showing here are data from a study that looked at glucose in the airway, so an airway secretion. Now, typically, this isn't something we typically think about, but airway secretions in the nose and in the lungs are typically glucose-free. This study, what it showed was when blood sugars increase, glucose increases in the airway. So they measured nasal glucose concentrations and correlated these with rises in blood glucose or blood sugar. And this dashed line here of 8 millimoles per liter is equivalent to about 140 milligrams per deciliter. And again, if you recall earlier, this is the cut point at which individuals who don't have diabetes or CF typically don't have glucoses above the 140s. And you can see here that as glucose levels rise above this threshold, nasal glucose secretions increase, highlighting, again, the importance of trying to achieve normal glucoses to protect airway and pulmonary health. So what is the treatment for CF-related diabetes? It's insulin replacement. And the goals of therapy are to maintain nutrition, maintain weight. It's important to monitor not just fasting blood sugars, but also post-meal blood sugars. And then as best as you can, I know this isn't always easy, but trying to normalize those blood glucoses to prevent deterioration of lung function associated with CF-related diabetes and to avoid long-term diabetes complications, those microvascular complications that we think about. This is an old picture, but I'm showing it here because it just shows a really the striking anabolic growth promoting effects of insulin. This is actually one of the first patients with type 1 diagnosed with type 1 diabetes to receive insulin treatment. So insulin was only developed as a therapy in the 1920s. And prior to that, if you had type 1 diabetes and made no insulin, that was a death sentence. And this is a boy who was able to benefit from insulin, and you can see really some of the dramatic changes after being treated with insulin. And this table here, again, just highlights some of the things that we've been talking about. The effects of insulin on liver: it decreases glucose release from the liver. It decreases those ketones or those acids that can be produced. Now, this is it increases glucose uptake into the muscle. It decreases amino acid or protein breakdown. It increases glucose uptake into adipose tissue and decreases adipose lipolysis and breakdown. So it's an important anabolic growth promoting hormone. And these are data from the CF registry, which has just long shown a really strong association between BMI and better lung function. These are some data from studies that have looked at longitudinally the effects of insulin on lung function in patients with diabetes. And you can see here that in the years preceding the diagnosis of CF-related diabetes, there's a decline in FEV1 and FVC. And after initiation of insulin, there's a stabilization in FEV1 and even an improvement in FVC going after these patients are followed 3 years out. We also see this improvement in weight and BMI after initiation of insulin therapy in these adults. And these are adults that range from 16 to into their 30s. And there are also data to suggest that insulin might even improve weight and lung function in patients with CF and pre-diabetes, even before a diagnosis of diabetes. Now, this isn't regular practice and something it's an area of ongoing research, but this is a small study that looked at using detamir, which is a type of long-acting insulin, in a group of kids with impaired glucose tolerance, so pre-diabetes, as well as CFRD, and it showed improvements in weight and lung function after being treated just less than a year. And so this is an area of active ongoing research, whether or not it might even help pre-diabetes. Microvascular complications I had alluded to earlier. It is important to screen for these after 5 years out from diagnosis, and to screen for some of these things on an annual basis. Neuropathy has been described in up to 50%. Retinopathy. So this is a screening that requires annual eye exams to look for eye disease related to high blood sugars, kidney disease, an annual urine sample, and then diabetes can also affect gastric emptying, which can make blood sugars more difficult to control. Again, macrovascular complications have not yet been reported, but with folks living longer and healthier, it's something that I think will be important to pay attention to in the years to come. So overall, it really takes a team. Patients need to be cared for by, I think increasingly we're realizing that if you can be cared for by a multidisciplinary team, that this can be really beneficial. Pulmonologists working with endocrinologists and dietitians, as well as a certified diabetes educator and social worker, all, helping to target optimal nutritional status and weight maintenance. And then really insulin regimens should be tailored to an individual's eating patterns and lifestyle. There are different ways to prescribe insulin. Basal bolus regimens, in other words, we can give long-acting insulins as well as short-acting insulins. Some individuals may require only mealtime injections. And then insulin therapies and regimens may change during illness, particularly with steroid need. Insulin needs may increase rapidly and decrease potentially after coming off of steroids. Insulin may be required with tube feedings. Physical activity can impact blood sugars. And hypoglycemia too is also something that folks deal with and without insulin. I wanted to mention that there have been a number of advances in diabetes technology, and I didn't go into this today, but Melissa has given some wonderful talks on diabetes technology, and I think we're really seeing increasing tools to help folks manage blood sugars, insulin pumps, continuous glucose monitoring, and closed-loop systems that hopefully will make some of the burdens of caring for diabetes and managing blood sugars easier. And then last but not least, I just wanted to highlight, some of the, potential exciting impacts of CFTR modulator therapy in years to come. And these are data that have looked at the effects of ivacaftor after it was used commercially for 5 years, and have shown that ivacaftor was associated, these are US registry data, with lower rates of CF-related diabetes compared to a comparator population. And this suggests that with increased uptake of highly effective modulators, that really these therapies, once they're widely available to the greater population over time, I'm really hopeful that this will modify the course of CF-related diabetes and the prevalence of CF-related diabetes that we'll see. In summary, folks with CF are really living longer, and with that, as folks are living longer, we may be seeing more CF-related diabetes. However, I think as we have more effective treatments, the prevalence of diabetes may change. And for now, having a diagnosis of diabetes is related to poor outcomes compared to folks who don't have diabetes. But insulin improves nutrition, it improves lung function, and there really are a number of technological advances that are available and on the horizon that can reduce the burden of managing diabetes and improving glycemic control. So, in sum, treating insulin deficiency, targeting hyperglycemia, improves weight, lung function, and lifespan, and you can make a difference to your health by taking care of your diabetes.